Can you tell us about the recent study published on smartphones and liver disease monitoring?
This was a study published in Journal of Hepatology, which was actually a study conducted in the early part of the COVID pandemic in 2020. The main aim was to look at the feasibility of using digital technology in patients with decompensated cirrhosis who were actually inpatients and prior to discharge, to assess what engagement would we get from those patients, and to look at some early clinical outcomes, particularly things such as readmissions. The system, which was called Siricare, used a combination of hardware, simple things such as a bioimpedance scale, blood pressure monitoring, assessment of heart rate and movement through a smartwatch, in conjunction with software apps, particularly to monitor things such as brain dysfunction, encephalopathy, as we call it, in decompensated liver disease, which is quite a common occurrence. And the patient had access through a smartphone and an overall app that would take these data inputs from the hardware and their own personal inputs on their well-being, fluid and food intake, and a platform would assimilate all this data and put the data in an organized fashion onto a clinician dashboard from which actionable insights, i.e. if there was a change in clinical state of the patient, a management step could be evoked so that you could try and modify the presentation of a particular complication of liver disease. So how successful was this? We found, firstly, 85% of the patients performed at least 4 readings a week, which we deemed to be good engagement with the system. We looked at the number of readmissions, which dropped by 38% compared to a standard of care contemporaneous group who were not on digital monitoring. There were less bed days both on the ward and in the ITU. And the need for interventions such as paracentesis, where we take off fluid from the abdomen, a common occurrence of accumulation of fluid in the abdomen called ascites, that reduced by 83%. So quite interesting result, albeit a small study where 20 patients were put on monitoring compared to 20 contemporaneous controls. What did the patients think about it? Well, they certainly, through feedback and questionnaires and interviews, suggested their anxiety levels about their disease were significantly reduced. They felt more connection with the clinical team and had an improved understanding of their disease and why they should take certain medications, such as laxatives, to reduce encephalopathy and brain dysfunction, their diuretics for their fluid accumulation. The program currently now is being funded by a large National Institute of Health research grant in the UK to do a large randomized controlled trial in over 214 patients to look at the clinical effectiveness across 12 sites.
How can this technology impact patient outcomes?
Firstly, one has to understand that these patients are very unwell when they're admitted to the hospital. And upon discharge, the severity of the disease is such that about a third of them are readmitted within 1 month, and 50 to 60% of patients are readmitted within 3 months. So there's a significant morbidity. And with every readmission, it actually has a worse impact in terms of their overall outcome. The advantage of daily monitoring is that one can actually assess an early change in disease severity and intervene in the community before that progresses. About 50% of the complications that occur are actually preventable. Things such as brain dysfunction caused by constipation or increasing fluid accumulation. So there's a significant advantage of being able to intervene early. And for patients whose disease is progressing quite quickly, to actually bring that individual up to the hospital and actually in a planned way admit the patient for a very programmed management and assessment, as opposed to having an unintended emergency admission and all the intended complications that often follow and the health economic impacts that there is from that. What about the patient? Well, this is actually a patient-centered approach. So it's tapered to an individual's disease severity and expression of disease. And as such, it means that, again, one can taper this as opposed to a one-size-fits-all approach, which is currently how we have to manage patients when we actually don't have regular insights on how that individual is in between outpatient follow-up appointments. It's clearly much more convenient and acceptable to the patients because they are actually largely managed at their own homes unless there is a need to bring that individual up to the hospital. And clearly an impact thereof from the risk of hospital-acquired infections. So people are only brought up to the hospital when their disease predicates that they need to be there for specific interventions. Patients also like the idea that there's a much easier access of communication through a simple text message, for example. They can actually convey concerns that they don't normally have to store up for an outpatient follow-up appointment maybe 4 or 6 weeks later. Now, a day-to-day change perhaps in their overall well-being or fluid status can be communicated. Also, clinicians often focus on specific symptoms and signs, but for the patient-reported outcomes such as appetite change, sleep disturbances, it's important to them. And these can be simply conveyed and perhaps an action given, which normally would be very hard to communicate. It's also a much more efficient use of resource allocation. So people who actually really need to be in the hospital have that access and availability because bed space perhaps is freed from individuals who don't actually need to stay within the hospital.
What possible challenges, ethical or otherwise, could this technology present to patients?
Clearly, any new intervention technology will have some barriers. And I think these have been addressed in part by a European Commission consultation on European health data space, which has been endorsed by EASL. For example, the concerns that there may be a digital divide created by the fact that many patients who use digital technology are often in an employed status or younger. How can one actually make this more accessible in terms of both cost of devices, internet access, being cognizant of that and perhaps looking at policymakers to try and make these things more accessible, to try and make sure that as a medical body, we have an increased awareness and an education program for future physicians to be more open to changing delivery, healthcare access and approaches, to be cognizant that we're in a much more multicultural society. So there are language barriers, and to be aware that clearly there needs to be translational opportunities put in for such technology use, be it the actual instructions for use of the technology and also to have an interchange between caregiver and the patient using a different language. There are clearly significant concerns about data protection. And I think this is something that we've all been more cognizant of in terms of GDPR, data storage, and for how long and who has access to it. And I think a lot of legislation is being put in place to try and address this specifically. Another concern is perhaps the disinformation that is increasing about the use of health data. The risk of perhaps unintended treatment being given. And I think this can be allayed to some degree by approaches such as Sericare, where the system itself is collating important data inputs from hardware and patient perspective. But at the end of the day, it is still actioned through a physician modifying the management plan. And clearly there needs to be a lot more education. And EASL, for example, through its patient forums, that's trying to look at the disinformation out there to try and make it more clear as to how digital healthcare approaches can be used. And I think there needs to be a lot more training when one tries to use digital healthcare to try and make it much more usable as a system. And the perceived benefits from that is more clear to the patients before they start to take up such technology.
How does the internet undermine patient literacy?
The way that the internet undermines patient literacy is that there is gives the opportunity to have access in millions of pieces of information, which in some case could be, a useful thing. But on the other side, it gives the opportunity to false information and information that is not accurate, or it is completely dismissing. And it gives, access to this information so people eventually can read and learn and be taught in a completely wrong way, and a way that is not effective for a personal health.
How does the internet support patient literacy?
When the internet was developed, this gave it an extremely important opportunity to humankind. We had the opportunity to have access to international information and global information in a very short period of time. This has brought a lot of things faster, and the access to information and all kind of goods and stuffs and things that happening, around the globe. We have currently the possibility through internet to have access, easy access, and with free of charge, which is extremely important also. Furthermore, the internet gives us the possibility to have a lot of credible information and updated information also. It's not the fact only that we have credible information, because we have access to every university, every source, every scientific committee, every scientific organization that exists. We have access in a very short period of time with a click. We have also access to the credible information.
What strategies can be used by clinicians and the public health sector to boost patient literacy while mitigating the negative aspects?
What I think is important is that scientific organizations, public organizations, in cooperation with civil society and grassroots movements and groups, should all unite and should all be united, and should all address, when there is a public health threat, should all address this threat in one voice. Being, the fact that there is, especially in COVID, this happened, we had many voices coming from all kinds of resources. This led to many people question what we had as a clear answer. So I think the fact that I believe that being united will address fake news and false information and all this movement that affects public health.